which is ophthalmology for the dermatologist, given by Dr. Baxter and Dr. Spencer from the Shiley Eye Institute. And are they connected so we can bring up their slides?
Hi, I'm here. This is Sally Baxter.
All right, so perfect. So Dr. Baxter, we're really happy to have you here today. Dr. Baxter graduated from Duke University and then received her master's in public health at the London School of Hygiene and Tropical Medicine. She then attended medical school at the University of Pennsylvania before moving out to California for her IM and Optho residency at UCSD. She served as the chief resident in ophthalmology and then pursued fellowship in biomedical informatics. And she's currently an assistant clinical professor holding positions in both the Department of Ophthalmology and Biomedical Informatics, where she's actively involved in multiple research projects. She's also the chair of the Departmental Diversity, Equity, and Inclusion Committees. And she's going to be presenting with Dr. Spencer. Dr. Spencer graduated from OHSU and then pursued a master's in biochemistry before returning to OHSU to complete his medical school training and receive a PhD, where his research focused in regulatory T cells and murine model of uveitis. He then moved down here to Southern California for his residency training at UCI, and then completed a uveitis fellowship at the Massachusetts Eye Research and Surgery Institution. He is currently an assistant professor at Shiley Eye Institute, where he specializes in ocular inflammation and retinal diseases. And he is also actively involved in research. Thank you both for joining us today. We're very lucky to have you.
Thanks so much for having us, and thanks for the introductions. So I thought I'd give an overview first. I'm not sure if Dr. Spencer's joined yet, but I believe he's also covering clinic at the VA today. So I'll get us started, and then when he joins, I'll be advancing his slides for him. So today we'll just go over a little bit of a review of basic eye terminology. It might have been a few years since you've looked at eye anatomy, and so we'll just do a brief review. And then there are two sort of larger sections of the talk. One is looking at ocular effects of dermatologic medications, and then ocular management, particularly for dermatological conditions that have ocular manifestations. And certainly not meant to be a comprehensive talk by any means. There are a lot of different conditions that have both skin and eye manifestations, but we discussed with your chief residents and sort of picked out a few areas that might be of particular interest. And so just to go over like a very basic review of the eye, the external photograph here shows the eyelid, and then the sclera, which is the white part of the eye. And the conjunctiva is a thin, clear membrane that overlies the sclera. Usually it's clear when it is inflamed, it can become red, and certainly conjunctivitis is something we'll be talking about in the talk today. The colored part of the eye is the iris, and then the opening in the center of that is called the pupil. And so if we take a look at the eye from the side here, sort of an axial view, you can see the front layer, the cornea, and then again, the colored part of the eye is the iris. In between the cornea and the iris, that space is called the anterior chamber. And we look there for inflammatory cells and a lot of autoimmune conditions that can have skin manifestations also manifest with uveitis or inflammatory changes in the eye. And that can be anteriorly or posteriorly. Behind the iris, we have the lens, and that's where we see changes like cataracts, certainly something that can result from steroid use and other medications. Behind the lens is this basically bag of jelly, for lack of better technical terms, but it's connective tissue called the vitreous. And then the tissue that lines the wall of the inside wall of the eye is the retina, and it's a photosensitive layer that'll convert light signals coming into the eye into an electrochemical signal that travels through the optic nerve to the visual cortex of the brain. And so, as ophthalmologists, we're basically, a lot of our work is physical exam based. We do have a lot of ancillary imaging and testing available, but the core of our evaluation is still a physical exam and looking at the different layers of the eye to be able to detect pathology and do our diagnostic evaluation. So yeah, our eye examination will include visual acuity, intraocular pressure, looking at the pupils, and then visual fields. We often call these our, ophthalmology vital signs. And then we'll take a look at the external appearance to the eye. That's where we do see a lot of the derm overlap. We might be looking at skin lesions on the eyelids, or, people will have atopic changes and so forth. Also, we'll be looking for proptosis or edema or erythema, which you can see with infection or inflammation. When we do our slit lamp exam, and there's a picture of me doing a slit lamp exam in the clinic, but we're using a microscope to look in detail at the eye, and we can look at the eyelids and eyelashes. And here I've just listed some of the terms you might see in our notes for different types of pathology. Cornea, the anterior chamber, iris, and lens. And then we'll use our special lenses to be able to look inside the eye at the retina and optic nerve, the retinal vessels, and so forth. And we can do that either using the slit lamp, or we also have the headlamps, which are indirect ophthalmoscopy, to be able to look at that, as well as I mentioned, a variety of imaging modalities as well. So we'll just dive right into some of the dermatologic medications that can have ocular side effects. I know one that the chief residents mentioned was of particular interest was Dupixent or dupilumab. And so, as you all know, this is the first FDA-approved biological systemic treatment for moderate to severe atopic dermatitis. Atopic dermatitis has traditionally been treated with steroids, and this offers sort of a steroid-sparing treatment course. It has anti-IL-4 and IL-13 activities, but something that came up during the clinical trials for this medication were that patients with Dupixent as their treatment were having higher rates of ocular complications than those on the placebo arms. And this primarily consisted of conjunctivitis and dry eyes, as well as ocular surface irritation. But interestingly, there was not much association with an increased rate of ocular complications among those getting Dupixent for other indications such as asthma or nasal polyposis. And the pathophysiology for the increased ocular complications with Dupixent is not totally clear, but the hypotheses out there have primarily been centered around something specific to atopic dermatitis, perhaps increased activity of atopic dermatitis specific ligands because of the blockage of IL-4 and IL-13. But this seems to be kind of specific to AD patients rather than just all comers who are using this medication, since they didn't see quite as much in the way of ocular complications for the asthma or nasal polyposis patients. And so this is just a graphic from a meta-analysis of the clinical trial data, and just basically what I had stated before, that those with in the treatment arms for the clinical trials for atopic dermatitis had a higher rate of conjunctivitis, so like 8.6 to 22.1%, compared to those in the placebo, which was about 2% to 11%. And then for the other trials, the incidence rates of conjunctivitis between Dupixent and placebo were very low and similar in both groups, less than 3%. And this just displays that graphically. The solo continued trial was the only one where they didn't really see a difference between placebo and the Dupixent arms in terms of conjunctivitis incidence. Now, we should note that these clinical trials were mostly they didn't have any formal ophthalmological evaluation. So it's hard to tell whether the conjunctivitis was allergic versus infectious. And there weren't like full slit lamp eye exams or anything like that. It was mostly based on evaluation by dermatologists and allergists. And so that was one limitation that the study authors mentioned, was that there wasn't necessarily very detailed characterization of the conjunctivitis. I did look up some case reports in the ophthalmology literature about Dupixent-related ocular side effects. And again, it's similar to what was reported in the dermatology clinical trials. There was blepharitis, conjunctivitis, various forms of eye and eyelid inflammation. So these pictures, which are unfortunately a little bit dark, but show the conjunctival inflammation, as well as congestion of the vessels and swelling of the lids here for this patient who had been on Dupixent. And this is a imaging modality that shows us the anatomy of the meibomian glands in the eyelid. And they show truncation of the glands as well as atrophy with use of the Dupixent. This is another case report of a patient who had a giant papillary reaction. And so you can see here on the external photographs, eyelid swelling, severe injection of the conjunctiva bilaterally. And then when you evert the eyelid and look at the palpebral conjunctiva here, we can see these giant papillae that they've shown in this photograph. Again, just another example, just to illustrate some of the more severe reactions that can be seen. This person actually had what's called cicatricial ectropion. So ectropion is when the eyelid turns out instead of being normally positioned. And you can just see general hyperemia and injection for him as well. But ectropion often it's eyelid changes that we see in the clinic can be age-related, or they can be secondary to medications. And in this case, the onset was after initiating Dupixent, so it was thought to be due to Dupixent use. And then this patient was treated with prednisone and had to discontinue the Dupixent because of the severity of his reaction. And you can see that his conjunctivitis, eczematous reaction of his eyelids and cheeks, and the ectropion actually resolved. So if you look at the anatomy of the eyelid here versus here, it actually normalized after he stopped the medication and underwent a prednisone taper. So the risk factors for someone having these kind of reactions to Dupixent include previously reported conjunctivitis, a baseline increased severity of their atopic dermatitis, and then there's some controversy about whether a positive dermatological response to dupilumab is protective or not. Some of the trials showed that if they did have a positive dermatological response, they'd be less likely to have the ocular side effects. Other studies showed that it didn't make a difference, or even that those who had a positive response in their skin findings actually did worse with their eye findings. So it's a little bit up in the air. And then a family history of atopic disease seems to increase your risk as well. And so as far as the management, when you're starting a patient on Dupixent, you might just want to ask them about their ocular complaints and symptoms to see if they have any baseline issues. It's not uncommon for patients with atopic dermatitis to have blepharitis or conjunctivitis anyway at baseline. And we'll talk a little bit more about that later. And you want to evaluate their potential for conjunctivitis before starting Dupixent therapy. So have they had conjunctivitis in the past? Do they have very severe atopic dermatitis? And do they have any family history? And it seems that the consensus guidelines around this say to just continue treatment even if you have previous or current conjunctivitis. Many cases, the conjunctivitis is very mild or time limited and will resolve. And if not, then you can refer to the ophthalmologist, and we're happy to co-manage. But in many cases, these patients can do well on the Dupixent, even if they have conjunctivitis, as long as the symptoms are managed. So if they only have dry eyes, and ocular surface irritation, you can prescribe artificial tears. If you do the over-the-counter artificial tears in the bottle formulation, you can go up to 4 times a day. If they're using it more than 4 times a day, then the preservatives in the bottles themselves can actually irritate their eyes. So at that point, if I have patients who require more than 4 times daily artificial tear lubrication, we'll go to a preservative-free formulation, which can also be over the counter, but it comes in these strips, and they don't have the preservatives that can irritate the eyes. Mast cell stabilizers can also be used. Once you get to the conjunctivitis and blepharitis reaction, where there's a lot of injection, eyelid swelling, anything like that, then you can consider topical corticosteroids. We also use calcineurin inhibitors, lid hygiene measures, and LipiFlow, which is a machine that kind of pulses the meibomian glands to help them express the blockages of lipid there. And so if you're using topical corticosteroids at that point, I think you'd want to send the person to ophthalmology to allow us to co-manage and be able to monitor them for any herpetic eye disease, as well as eye pressure elevations. So these are just examples of patients who, again, had fairly severe reactions to the Dupixent and then resolved. And these were examples all related to tacrolimus ointment treatment. And you can see resolution of their conjunctivitis, as well as some of these eczematous changes on their eyelids. Moving on, I thought we'd touch on retinoids, which are commonly used treatments for acne, psoriasis, seborrheic dermatitis. And again, the most common reaction here is blepharitis or conjunctivitis, dry eye syndrome. Patients can get some photosensitivity and get a dermatitis of their eyelids. Because of the ocular surface irritation, they can get contact lens intolerance or have some tear film instability that causes them to have transient blurry vision. And if they have these reactions, usually you can just continue the retinoid treatment and just ensure that they're doing artificial tears or using warm compresses, and sometimes topical antibiotics can be used to help with the conjunctivitis. But usually these are mostly based on symptom management, and you don't necessarily need to discontinue the retinoid treatment. There are some more rare complications that have been reported to be associated with retinoid treatment, and that includes pseudotumor cerebri or idiopathic intracranial hypertension, corneal opacities or cataract formation, as well as abnormal retinal function. So what that would manifest as is the patient comes in with, they're complaining of decreased night vision, decreased color vision, or having susceptibility to glare. And if they have an existing retinal dystrophy or degeneration, you want to avoid retinoid treatment. So those are good things to ask about. And if someone does endorse some of these vision changes, you'll want to refer to us in ophthalmology. We have various retinal testing that we can do to evaluate, and that would be kind of a more severe complication that would probably warrant consideration discontinuing the retinoid therapy. This is a picture of a patient who had bilateral optic disc edema and intracranial hypertension after using topical vitamin A. For other common meds that you might be using include Botox and fillers. And again, I'll just be going over this briefly, but for Botox, perhaps the more feared complication from the patient perspective is getting the droopy eyelid or ptosis. Patients can also get dry eye or transient diplopia or double vision. Luckily, these are short-lived, as the effects of Botox generally don't last. It's not like a very long-term effect. And in the interim, you can use alpha agonist eye drops like aproclonidine or phenylephrine to help bring the eyelid back up. And so this is a patient who had Botox injection that resulted in a right upper eyelid ptosis. And then with the she had aproclonidine drops, you can see that it improved the appearance of the eyelid. And then this is a couple months later, she's pretty much back to baseline. Fillers are another common cosmetic procedure that's done by ophthalmologists, dermatologists, plastic surgeons. And this is really one where you can get into major ocular complications, primarily through, iatrogenic embolization of the ophthalmic artery. And so this is a picture of a patient who was getting a filler injection and presented with no light perception in the right eye. And you can see this picture has just total occlusion of the ophthalmic artery, including the cilioretinal artery as well. That's why you don't see that cherry red spot, because the whole pathway has been blocked. And then 3 months later, she came in back for follow-up, and lots of fibrotic changes, extensive atrophy of the retina. And despite sort of a whole milieu of treatment, like injection of hyaluronidase at the time when her vision was noted to decrease, acetazolamide. I think she might have also tried hyperbaric oxygen therapy, but none of it was effective, and she was still no light perception in this eye. And I think she was in her 20s. So this was obviously a very tragic complication from the filler injection. So what are some strategies to avoid embolization? Some people recommend aspirating before injection. It can be hard because the filler is very viscous and you might not always see a flash if you're in a vessel, but trying to use smaller needles and syringes and cannulas, or using blunt needles and micro cannulas, doing low pressure injections of very small amounts rather than larger bolus injections, trying to limit the total volume of filler that's going in, and avoiding injection into pre-traumatized tissue. But the main thing to remember that here is prevention is key. If you can, use your filler injection technique in a way to avoid impacting the vessels that feed to the eye, then that is ideal, because really there's no safe and reliable treatment for once the embolization occurs. There's all sorts of things that we try, including ocular massage, try to give eye pressure lowering eye drops to bring down the pressure. If you call in ophthalmology, we can do an anterior chamber paracentesis, which is when we put a small needle in the eye and try to drain the fluid to decrease the pressure. There have been some case reports of hyperbaric oxygen treatment helping, but really there's not a consistent treatment that's been shown to help bring the vision back once that embolization has happened. And so this is really something to be careful about, since it is a very severe ocular sequela for a cosmetic procedure. All right, so let me see if Dorian is on. This part, Dr. Spencer, who's our retina uveitis specialist, is going to talk about Plaquenil. Let me see, I don't think
Hello.
Oh, okay.
Can anybody hear me?
Yeah, we can hear you.
Great. Okay. So thanks for having me. It's a pleasure to be here. This is a little awkward from the VA because I only have the sound. And so I have our presentation. I'm basically going to ask Dr. Baxter to advance them, because I actually am not seeing the video that you guys are seeing. So I'm going to go on to the next slide, which is the hydroxychloroquine. And so the question is, obviously this is used a fair amount in dermatology. It can potentially have ocular sequelae. There's one in particular that we pay attention to, and the others are relatively trivial or rare. And so I'm going to talk about that, and there are a few other topics. And if just in case I get cut off, because this has happened a couple times while I was listening to Sally's, just give me a minute to log back in. For some reason, it seems to kick me out. So, okay, so hydroxychloroquine, obviously we tend to call it Plaquenil. The main possible sequelae that we worry about is with the retina, and that can lead to a bullseye maculopathy, which I believe you can see there on the right. And so just to dispel some kind of misconceptions people might have, we're not looking for this. If somebody already has this, if we see this, then they're in really bad shape. So we don't actually want them to get to this point. We're looking for things that would precede this, that would keep the retina from having this appearance. Because if you're looking at this, then essentially damage has been done and the patient has already lost vision. And so, so that's really the most severe consequence we look for. Thankfully, it's quite rare. You can have Plaquenil accumulating in some of the cornea. That's essentially trivial. And then just in my review, I read that it can affect the ciliary body, but that essentially almost never happens. So we're not going to get into that. And so to prevent this bullseye maculopathy from happening, people often see a retina specialist. In my opinion, it doesn't have to be a retina specialist, but being one, that's, I see these patients too. And so we monitor with what we call a DFE. I think Sally may have addressed this. That's a dilated fundus exam, just to make sure we don't see that. We do visual field testing, and we do a macular OCT. The OCT being ocular coherence tomography. It's kind of like an ultrasound using light waves. And I'll show that in the next slide. And so we like to see the patient at baseline before they start therapy, or fairly soon after they start therapy, just to kind of see what their eye looks like and know if there's any pathology that we need to be aware of beforehand. There are funny retinal dystrophies and such that could look like this, and you would be very confused if someone started off looking like this. So once we see them, the standard of care often is to see them yearly and to repeat the testing, although honestly, this essentially, you never see this sequela before 5 years and probably even more like 7 years that you've been on the medicine. Although routinely we do check just, I think, in part to get the patient in the habit of coming in. And so once they do reach the 5 or 7 year mark, that we know we're going to be seeing them again. And so, as I mentioned, early detection is essential because otherwise it may result in irreversible retinal damage. The percent reported in the literature is about 1% at 5 years, and it does increase with time. I've seen, I can't tell you how many hundreds of patients I've seen screening for Plaquenil. I think I've had to stop it 3 times, so it's not very often. And then, Sally, if you don't mind advancing to the next slide. And so this is what a cross-section of the retina looks like on the right. This is OCT of the macula. And so we see the retinal layers. You're not going to see my mouse because I can't see it either. But basically, if you look in the middle, there is a bright white layer at the bottom. It's very bright. And then there's a slight white layer just above that is discontinuous. And so in the middle is where there's the fovea, and you can see a little bit of this bright white layer at the bottom. Those are the photoreceptors that are intact, but they're missing just to the left and right of that. And that's what gives this ring scotoma. If you look on the left, this is the visual field output. And so the patient is clicking with our visual field machine to show what they can see. And you can see they actually, so dark is what they do not see, and then light is what they do see. And so they still do have central vision, but then they have this ring scotoma. So they're going to notice that they're basically looking through like a straw or a tunnel if this advances to the maculopathy. And at that point, that's irreversible. So we always try to catch them long before then. And so we're looking for, yes.
Sorry, a question came through the chat. I just want to make sure that it got addressed before you moved on from Plaquenil. Was about often the dermatologist will see a skin hyperpigmentation for patients on Plaquenil that may not be related to dose or duration of the drug. Do you see any association between retinal toxicity with skin hyperpigmentation?
So the short answer is no, I'm not aware of that. I honestly, that is, I can't say that's something I was even aware of, just because we do our own monitoring. That would be interesting to look, but I have not heard of any association between the two. And honestly, for us, Plaquenil, really, it is dose dependent and duration dependent. So if that manifestation occurs independent of those, then I would say there's probably no association. So thanks for bringing that to my attention. So we'll go on to the next slide then. So the next topic I was asked to address has to do with steroids. Obviously, steroids, as a uveitis eye inflammation specialist, I have a love-hate relationship with them. They can be very useful. They're the only effective medicines for quelling inflammation acutely, but they have, as we all know, lots and lots of terrible side effects if you continue them long term. And for the eyes, there are really 3 that we think of, and I mentioned a couple others, but those are kind of trivial or indirect. And so the first one is if you are on steroids for a significant amount of time at a high dose, and I'll kind of get into what that means, but that's typically many years of either high dose drops or high dose systemic medicine, then you can develop a cataract at a young age. It's kind of a particular type of cataract. It's not the type that is associated with age, when you think of your grandparents or so, but it's actually, we get this opacity that develops on the back of the lens, and it's what we're seeing on the image of the right. It kind of looks like wax paper. And so that's basically what the patient sees too, is they feel like they're looking through wax paper. And even though somebody might be very young, it still can be very disabling for them. And so we take care of that surgically, and I'll talk more about that on the next slide. The second issue is a certain segment of people can develop increased intraocular pressure, so IOP, and that can lead to glaucoma. And so we have to look out for that too. And then there's a third condition that many of you may be less familiar with, that steroids can have this effect on the retina. It's called central serous chorioretinopathy, or just retinopathy, so CSR, and I'll mention that. And then the fourth one for skin atrophy, that's fairly obvious. You know, we try not to inject steroids into the eyelids, as they can cause some atrophy. You know, that would be for like a chalazion or something like that. And then obviously steroids long-term can increase systemic risk factors, diabetes, high blood pressure, obesity, and so forth, and those can have deleterious effects on the eyes. And so if we go on to the next slide, so again, this particular type of cataract called posterior subcapsular is just because the opacity is on the back surface, the posterior surface of the lens. That is what we see with prolonged steroid use. It also happens for people who are diabetics, for poorly controlled diabetics, and in my case, people who also have uveitis, or just use the steroids for that, to control the uveitis. A few other things can do it, like radiation, and rarely a few genetic disorders. And so someone really has to be on a fair amount of systemic steroids for this to happen, or have bad diabetes. And I think a decent rule of thumb is if you're starting to get into other systemic problems, if they're starting to become cushingoid, then that's probably when you have to worry about the cataracts. Otherwise, you know, I have treated, I'm sure, well over 1,000 patients with a good dose of systemic prednisone, you know, 60 milligrams daily for a week, with weekly taper of 10 milligrams. And I never ever see this, and I'm not even concerned about it. Even going out a few months, you know, with a reasonable taper, there's no risk of this happening. So it really has to be high dose steroids for several years, or if you have, you're using topical steroids, which of course you won't really be doing on the eyes. For this type of cataracts, we don't really think of topical steroids on the skin or other types of steroids having this effect. It really has to be either systemic or ocular. And okay, so we'll go to the next slide, and Sally, if you don't mind bringing it to my attention if anybody asks a question.
Yeah,
so
there was
next
a question about after how much time for referring patients for evaluation of the use of topical steroids on the face or oral steroids. I think you mostly answered it. I would just also add that because there is variation in, like, some people are on steroids and don't have any problems with cataract. Other people do, and part of it is just symptom based, right? The patient's endorsing blurry vision or increased glare, then refer them our way, and we're happy to take a look. But we don't necessarily, for topical steroids on the face, don't need to do like routine asymptomatic screening or anything like that.
Yeah, I totally agree with that. Thank you. And so for the next condition that steroids may cause, it can increase the IOP. And if the intraocular pressure remains high for a long time, and again, this is this also relates to duration and strength of exposure. But if the pressure is very elevated, say 30 or above, for several months, then you may start to see an effect on the optic nerve. So if we look at the right, you see a normal optic nerve head, and then the small arrow inside the optic nerve is showing the cup where there's no nerve tissue. That's kind of the empty space. And then if you look around that, that's what we call the rim. And there's this very thick rim of healthy nerve tissue. And if you look at the bottom parts, the cup is much larger, and that's basically because all the rim tissue is missing. And that is the effect of increased ocular pressure on the eye. And so this type of finding is typical of what we see in glaucoma, and it is essentially an optic neuropathy, and for the most part is reversible, but also is a kind of a slow, insidious process. So we often are able to stay ahead of it by reducing the ocular pressure. And we have right now at least 5 different classes of glaucoma medicines topically that we can use, as well as 1 orally. And then there are surgical approaches. So this is something we generally have a good handle on as ophthalmologists. And I'm just going to go through some of the text I have here on the side. So for the general population, about 1 out of 3 patients approximately is susceptible. If you give them high-dose steroids, the eye pressure will increase. Of those 1 out of 3, typically nothing happens after a couple weeks. And again, I have prescribed oral steroids to, I'm sure, well over 1,000 patients. And I see them, throughout their prednisone taper. And I virtually never see any issues with this. And so during that time frame, of course, I don't continue systemic steroids longer than a few months. And so it's really the highest susceptibility is with topical steroids. And then after that, there is would be systemic, and then much lower down on the risk strata would be topical elsewhere. And then on my next slide, I'll get to a few other routes where we can get into trouble. And then if there aren't any questions about that, I will move on to this last pathology that can result from steroids. So steroid-related central serous retinopathy, which we call CSR, sometimes CSCR for choroidal retinopathy. And so this is a little bit of a mysterious condition because it can happen due to steroids or it can happen completely independent of steroids. It's thought to occur in about 1% of the population, at least per the literature, although that seems a bit high to me. And that includes all comers, so independent of steroids and those steroid dependent. For whenever this happens, so this is what we're seeing here is an OCT again of the macula, and you see this kind of dark triangle under the retina. So that's the serous components. And so as you can imagine, the photoreceptors, instead of sitting against the back wall of the eye, they're kind of floating, which isn't perfectly healthy for them. They actually are supposed to be somewhat tightly opposed to the back wall of the eye. That's where they get their nutrients and oxygen supplies. So when they're floating like this, you can imagine they're holding their breath a bit. And these look okay, and this person may in fact still see well. This looks like it was rather acute. After it's been going on for a while, the retina starts to look fairly shaggy and edematous. And so 90% of the time, if somebody has this, if it's due to some type of steroid exposure, we just try to discontinue that. And we talk with whoever's prescribing it. And most of the time that's possible. If it's not possible, then honestly, it can be rather tricky and kind of a mess. So I'm here at the VA today. It reminds me of one patient I've seen here who has, I believe, bullous pemphigoid. I haven't seen him since before COVID, so I'm assuming he's still doing okay. But he was being treated with bullous pemphigoid with a fair amount of systemic steroids, and he had really chronic CSR, and he didn't have great vision, and it was a real struggle to try to manage that. But most of the time, unless somebody has a malignancy or something like that, we're able to work with, our other colleagues who are prescribing the steroids, trying to minimize them. Sometimes we do get in trouble with, asthmatics or people who have tumors or severe rheumatologic conditions. Let me see. So I have seen this frequently. This is going to the text at the bottom on the left. So I've seen this frequently from topical drops, which on the eye, which we're responsible for, frequently from oral steroids, not so much IV because people don't tend to get IV for very long. But I have seen this honestly from steroids that have been administered elsewhere on the skin. I've seen this from quite a few times from inhaled steroids for allergies. So just so you think of, like a nasocort or something like that. I've even seen this from people who get a joint injection, which may seem a little bit distant from the eye, but I've literally seen this. Somebody gets a joint injection in their knee, and then this happens. So again, this comes back to what Sally was saying earlier. This is not something that I recommend or anybody recommends screening for, but if the patient reports they're having some blurriness, then that definitely warrants our attention. Go ahead.
Sorry, Dorian, just to let you know, Dr. Dorschner put in the chat that the patient that you were referring to with bullous pemphigoid has been tapered off prednisone.
Great. Okay, that's nice to hear. I haven't seen him. We might want to refer him back to ophthalmology if you know who it is. I haven't seen him since before COVID, so I think I'll have a hard time tracking that person down. But if that's possible, we should check in on him again. Okay, so moving on. So the next slide says ocular management of dermatologic conditions, and we're going to talk about Stevens-Johnson syndrome, DEN. And then, so obviously this is kind of a very different situation where these patients obviously have very severe dermatologic conditions, and there's no mystery about whether or not they should be referred to ophthalmology. So in Stevens-Johnson, and then of course TEN, it's reported in the literature that the ocular involvement is about 80% of the time, which basically means that we want you to consult us 100% of the time. I'm sure Sally has had this experience. I haven't seen these patients honestly since residency, although I saw enough that I remember them well. And the worst patients I saw were those who were being managed at some other hospital, say for a couple weeks, and they did not have ophthalmology, and then they transferred to us, in my case, the UC Irvine, and their eyes were a total disaster. So we want to avoid that, and maybe we can discuss this later at the end, but my lasting memory is often people recover systemically, and their skin can recover okay from Stevens-Johnson, and the most symptomatic lingering complaint they have is their eyes. And so, 6 months later, they might be doing systemically okay, but their eyes are making them absolutely miserable. And so hopefully when we're consulted in time and when we are aggressive about our management, we can minimize the likelihood of that. And so when they present acutely, we typically see them daily. I even remember seeing them twice a day when I was a resident. The mainstay of treatment is very aggressive lubrication. So, typically these are ICU or burn ICU patients where they can get hourly eye drops. They often get a chamber, which is like a humid chamber over the eye. We frequently, proactively are, as we call it, sweeping the fornices. So we were removing all of the debris that's building up because they tend to get scarring. As Sally mentioned earlier, they can, in her other patients with the Dupixent, you can get scarring of the ocular surface. And then when the epithelium of the cornea starts to erode off, then we typically administer topical antibiotics too. They're often topical steroids. It's very common that we end up placing amniotic membranes on the eye. And then they typically have a ring that fits into the fornix, so the very edges of the top and lower eyelids, to prevent these adhesions, which are symblepharal. And then on the right, I listed this chart that I got from our academy that shows the prevalence of the complications. And then so you can see it's not really until about week 4, so about a month in, that they start to get this scarring of the conjunctiva, which are the symblephara. And then ankyloblepharon is when the eyelids have actually completely adhered to the ocular surface. And so you can't open or close the eyes, and you can imagine that's a real mess. And so I'll go on to the next slide. And so once the acute phase is resolved, then we're managing the residual damage to the ocular surface. This often involves continued aggressive lubrication. Typically, the patients really don't make the adequate tears anymore because so much of the eye surface has been destroyed. There's typically topical cyclosporin. Often there's scleral contact lenses, as well as serum tears. And then what the underlying pathology ends up being is typically the goblet cells of the ocular surface have been destroyed. The limbal stem cells, which really are the corneal stem cells, they're at the very edge where the cornea meets the conjunctiva. Those often get destroyed. And if you don't have those, then you will not really have much of a cornea. And so there are surgical approaches where we will place autologous buccal membranes on the eye. You'll do a limbal stem cell transplant, which is kind of like it's a lamellar corneal transplant, so just the edge of the cornea is transplanted. There can be eyelid reconstruction, and then full-on corneal transplantation. And so these patients, the truth is, I don't really see these patients even as a uveitis specialist. They tend to go to cornea specialists and oculoplastic specialists because they do the surgery. And these patients honestly don't really have a need for systemic immunomodulatory therapy. It's all topical. And so on the bottom is a picture of a patient who had a corneal transplant that through the adhered eyelids. So once you have the ankyloblepharon and the eyelids have completely adhered to the eye surface, it can't open. And so if you want them to see, you do a cornea transplant with a prosthetic cornea. So this is plastic that goes through the eyelid and through the cornea. And obviously that's kind of an extreme example. It can give them actually quite good vision. There's a lot of long-term complications, meaning glaucoma and such, and you have to remove their lens because you'll never be able to do cataract surgery through this, so you remove it prophylactically. And then if they ever develop any type of retinal pathology, you will have a very difficult time treating that. And so if there aren't any questions, I'll move on to the next slide. And so ocular cicatricial pemphigoid, unlike Stevens-Johnson and TN, is something that I see a lot. And so when I was in Boston, we were kind of the epicenter of, as we call it, of OCP. And so on any given clinic day, I never saw any fewer than 3 of these patients, and it was often more like 6 or 10. And so I've literally seen many hundreds, if not thousands, of patients like this. And here at UCSD, these typically come to me as a uveitis specialist, where I manage the treatment, especially the immunomodulatory therapy. And so OCP is considered a subset of mucous membrane pemphigoid. And just because many of you will probably ask this, we very, very rarely see ocular involvement in bullous pemphigoid. Of the many hundreds of OCP patients I've seen, I think I've seen maybe 1 who actually their underlying pathology was bullous pemphigoid. And so they're just, there is a very stark demarcation between the two. And so for people who have mucous membrane pemphigoid, and it's not clear to me, maybe you can speak up about how often that's managed by dermatology as opposed to other services. The ocular involvement is about 60%, which basically means they should all be referred to ophthalmology. The typical initial symptoms are eye redness, irritation, discharge. So it's basically a chronic conjunctivitis. And most of these patients honestly have been treated and managed for just a kind of non-resolving chronic conjunctivitis for a good year or 2 or 3 before the definitive diagnosis is actually made. In some cases, it may remain relatively mild, but you never know. So it's worth referring it so we can monitor it. Mild cases can be managed with dapsone. I virtually never do that just because the patients who come to me have typically failed dapsone, although it can work. As you know, it's basically an antibiotic. It works for kind of mysterious reasons. I just almost never prescribe that. So when I see patients, I'm typically using the bigger guns. And so I'm using some type of immunomodulatory therapy, either methotrexate, Rituxan, IVIG, or the alkylating agents. And then so we diagnose this on the eye surface with a conjunctival biopsy, and then we do immunofluorescence for the autoantibodies. When I was in Boston, we did all of that ourselves. We did the biopsy, we did all the pathology. We had samples sent to us from all over the country and even all over the world where people strongly suspected OCP, but their pathology result was negative. We often would find them to be positive using kind of our enhanced technique, but also we often end up treating the patients presumptively because pathology is not 100%, and there's not a whole lot else that's going to look like this, assuming the patient hasn't had, some type of caustic chemical exposure or environmental exposure. And so, so this is a symblepharon. This is where the you can see here on the image on the right, the conjunctiva is scarred, and so there's this adhesion, particularly right in the middle. At 6 o'clock, you can see it between the lower eyelid surface and the eyeball surface, and you can see the fornix, which should be much deeper and frankly shouldn't be very visible, is, as we call it, obliterated. So there's not really much of a pouch there. And then if we move on to the next slide, so my fellowship was with Stephen Foster, and so I go by his classification system, even though there are others. And so his is really a clinical classification. So in stage 1, there's subepithelial fibrosis, which is just basically the conjunctiva is getting kind of thick. In stage 2, the fornix is becoming short, like we saw on the last slide. Stage 3 is where you're developing the symblepharon, so scar tissue of the conjunctival surface. And then 4 is what we see here on the right, where the ocular surface is completely keratinized. And then this is, unfortunately, a terribly end-stage eye. I suspect that they have ankyloblepharon, and so the eyelids will neither open nor close. And then you're in really bad shape. And I mentioned the limbal stem cell deficiency is one of the major complications. There's also trichiasis, where the eyelids are frequently deformed and turn inward, so the eyelashes end up rubbing against the eyes. That can lead to corneal ulceration and opacification. Sometimes they perforate. You could have a lot of damage to the anterior segment of the eye, which is a term we use for the area between the cornea and the lens. That's where the fluid drains out, and if that is damaged, you can develop pretty severe glaucoma. And then with all of the steroids we use, patients frequently develop cataracts. And so obviously this is, and we'll go on to the next slide, that's very problematic. And so just like that other full lid thickness cornea transplant I showed before, we often end up transplanting these with a plastic cornea, because a human cornea will fail just because you need the limbal stem cells to maintain it. And so in the absence of that, you have to put a plastic cornea. These do okay. I did a lot of these in Boston as well. They can really grant people some useful vision. Unfortunately, typically they develop a fair amount of complications, meaning infections and things like that. So we're still lacking for a good long-term treatment for this. And then we also frequently will do either epilation or cryo treatments of the eyelids and eyelashes to treat the trichiasis. And then once things are quiet on immunomodulatory therapy, we also frequently will try to reconstruct the fornices, just so that the patient, for example, can put a contact lens in. I believe that's my part, and then I'm going to hand it back to Sally. I don't know if there's any other questions right now. If not, we can. I think we have 5 minutes left, so I'm gonna let Sally get to her part.
Well, all I had remaining was just a little on atopic dermatitis, which we talked about a little bit with the Dupixent part. Because it is only 5 minutes left, I just wanted to make sure that we addressed any questions that people might have, particularly about the medication side effects and the other conditions that Dr. Spencer mentioned. So I don't know if your convention is to just put things through the chat, or if anyone wants to ask their questions through that. I see Dr. Sprague's on.
I was gonna say, does anyone have any questions? I know we thank you guys for addressing the questions in the chat as they arose. Anyone have any questions that have come up that they weren't able to enter into the chat?
Yeah, this is Rich Gallo. I might have missed it, but I've heard quite a bit of work on the IL-4 receptor alpha regulating certain secretory cell function, and that is a likely explanation for the both the conjunctivitis as well as the red face that we see in a subset of these patients. Can you comment on that?
I will admit I am not super familiar with the literature around that. I know Dr. Spencer hasn't, with his immunology background and his training in uveitis. Dorian, do you have any knowledge on the IL-4 alpha?
So I've heard that much. I've also, I know that it's being used, it's starting to be used for atopic ocular disease. I have not seen those patients, honestly. They've gone to the cornea service, but I'm aware of a few patients kind of by hearsay that have done very well with the treatment for anti-IL-4, but otherwise, I'm not quite sure if that was a question or.
It was
I just
more
wanna make sure I-
mechanistic. Yeah, it was more mechanistic, just that the reason Dupixent has this effect on the subjects, and of course the lack of penetrance in everyone is not clear, but it's that some secretory cells, both around the eye as well as sebaceous glands in the on the skin, require IL-4 signaling for normal function. So by blocking that, you then result in the side effects we see.
Yeah, some have
Yeah.
postulated, particularly on the conjunctival goblet cells, and some of the normals or mucus secretion gets affected when the IL-4 is blocked. But that's as far as my understanding goes. So.
Yeah, I think I'm not sure I can speak more knowledgeably on that either.
Anyone else have any questions or comments? Otherwise, we have a couple minutes if you wanted to talk about atopic dermatitis.
Sure. So we talked about the conjunctivitis and blepharitis component. Atopic dermatitis itself, so even if you don't have Dupixent treatment, can be associated with ocular surface disease, as we're talking about. Keratoconus, which can come from like chronic eye rubbing, which I have a picture of later, cataracts, glaucoma, and herpes eye infections. So those are all things to be aware of in your atopic dermatitis patients. Keratoconus is this interesting corneal ectasia, which is a misshaping of the cornea. It's actually one of the most common reasons for corneal transplant. And so it is, atopic disease is a risk factor for it because of chronic eye rubbing and actually causing a misshaping of the cornea. So that's something to keep in mind, as well as we had mentioned before, with steroids, you can get a posterior subcapsular cataract. With atopic dermatitis, sort of the classic association is an anterior subcapsular cataract. Again, it's not something we need to do routine screening for, but if people are complaining of decreased vision or glare, then we're happy to evaluate. These are just pictures of herpes eye infections, and the literature has shown that patients with atopic dermatitis are more susceptible to herpetic eye infections. So we do want to use steroids, particularly topical steroids, on the eye with caution. And so if you have a patient with eye pain or redness, we're happy to take a look and manage, especially if they have a herpetic eye infection. I know we only have 1 minute left, so I won't go too much into detail, but for ocular rosacea, this is something that there's a lot of overlap with cutaneous rosacea, and there can be discrepancies between the skin findings and the eye findings. A lot of what we'll see include incipated meibomian glands, telangiectasias on the eyelid. You can get corneal infiltrates and edema and this neovascularization or abnormal blood vessels here, as well as Demodex infestation. And we'll do a combination of oral and topical treatments, particularly doxycycline is the most commonly used antibiotic. Topical steroids, again, as Dr. Spencer mentioned, we do monitor the eye pressure. And then some studies have shown effectiveness of tea tree oil applied to the eyelids for the Demodex. We do lid hygiene measures, but again, this is kind of a long-term chronic remitting problem, similar to cutaneous rosacea. So we'll follow these patients over time to manage their ocular symptoms. I think main pearls, anyone with existing risk factors, prior eye conditions, may benefit from a baseline eye exam prior to initiating treatment. And so for your patients on Plaquenil, or if you have someone who may have an ocular history prior to starting something like Dupixent, we're happy to see them. Oftentimes, you may not need to discontinue the dermatological treatment, even if side effects arise, particularly if it's just ocular surface irritation or mild conjunctivitis. Certainly for things with retinal or optic nerve sequelae, there'll be greater consideration for discontinuing the medication. But as Dr. Spencer had mentioned, several of these conditions can have vision-threatening ocular complications. some of which can be very common. So we're happy to co-manage with you and see anyone that you send our way, and happy to take care of these patients alongside you. So I think that's time. Sorry for running a little over.
Thank you, Dr. Baxter, Dr. Spencer. That was a great, very pertinent and informative talk. We really appreciate you taking the time to join us this morning, and we appreciate your expertise caring for these mutual patients and our continued relationship with ophthalmology. Thank you so much.
Yeah, thank you for having us.
Yeah, thank you guys for having us.
And then thank you everyone for joining us this morning. You have the QR code here, and then I'll look forward to seeing the UCSD faculty members in the faculty meeting coming up. And we have, in case you can't see Dr. Spencer, there's a number of comments from the chat just thanking you for taking the time to be here this morning.
Yeah, thank you. Okay, take care.